Good day, everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in Atlanta, Georgia. I also have a position with the National Cancer Institute of NIH, and it's my pleasure to welcome you to this version of the webinar series that the Coalition brings together in collaboration with colleagues at the National Institute of Health to focus on research related to the elimination of hepatitis as a global health threat around the world and including in the United States. Today, we're going to be looking at ways of improving access to care for primary liver cancer, hepatocellular carcinoma globally, and looking at some of the research being done internationally, including that looking at the importance of HIV co-infection and how to address that additional risk. Next slide, please. This is part of as I mentioned, a webinar series that was started in 2021. We have a rich repository of information on a variety of topics. Please go to our website at globalhep.org. To view those, the videos are there in full for the presentations, separated by the individual presentations. The slide sets are there, as well as a synthesis report for each webinar so that you can quickly understand what was covered and go to the area of greatest interest to you. Next slide, please. I want to thank my colleagues on the organizing committee. That you'll be, some of whom you will be meeting in just a moment, but they represent many of the institute and offices at NIH, in addition to the US CDC. Next slide. This is our agenda for today with the different topics that are outlined there, and you'll be hearing from three researchers and their presentations. You'll also be getting some comments from a hepatologist who's involved in some of this research in Africa, just to give you some local context about the importance of that research in efforts to improve hepatitis care and HCC care in African countries. I think at this point, I'll turn it over to my colleagues who will be moderating the session today. That's Dr. Betsy Reed-Conley and Dr. Joanne Renato. And I'll turn it over to Betsy and Joanne.
Hello, let me extend my welcome. And I would first I'm Dr. Betsy Reed-Conley in the Division of Cancer Biology at the National Cancer Institute, NIH. And I would like to, first of all, share some opening remarks in a video that our acting National Cancer Institute Director, Dr. Douglas Lowy, provided to us. He sends his regards and unfortunately was unable to attend today because of a previous engagement. So Lindsay, if you would start the nice video that Dr. Lowy provided for us.
Good afternoon, everyone. I'm pleased to introduce today's session, where we're going to be hearing about liver cancer in 3 different countries: Vietnam, Taiwan, and Uganda. Liver cancer remains one of the major killers from cancer globally. It takes the lives of close to 500,000 people each year. I'm going to focus on what happens in the United States as a complement to the presentations that you'll be hearing in a little bit. As we think about trying to end cancer as we know it, which is one of the things that the Biden administration urgently wants to do, liver cancer falls into one of those cancers where we haven't made the kind of progress that we hope to, where only 1 in 5 patients diagnosed with liver cancer actually survives 5 years or more. Because of increased rates of liver cancer over the last few years, and increased mortality as well, NCI is investing in multiple areas of liver cancer research. They include prevention, early detection, treatment, and clinical trials. And in the intramural program, the Center for Cancer Research, or CCR, there is a specific liver cancer program. There have been some noteworthy changes in the demographics in the United States over the last few years that I would like to review on the next 3 slides. First, when it comes to incidence, the incidence, particularly in males, has plateaued or potentially even gone down, and it also has plateaued among females. But if you drill down on the age-specific differences when it comes to incidence, you see that there is a major change in the individuals 50 to 64 years of age, but that the incidence continues to increase for individuals who are 65 years or older. And when you look at mortality rates also have reflect that change, where Hispanics, Asian Pacific Islanders, and Blacks all have a decrease, and whites in the 50 to 64-year-old range also have it, although that's not shown on this slide. The disappointment is that American Indians and Alaskan Natives have not benefited in any way from this. We do not really understand what is accounting for these changes, and therefore it's eminently worthy of exploration. Finally, I want to mention the Louisiana Hepatitis C Elimination Plan, or Hep C Free Louisiana, where the goal is to achieve statewide elimination of infection from HCV, diagnosing 90% of those infections and treating at least 80% of them. This plan is quite successful, at least in the short term, and it's really worthwhile for us to consider whether to take such a plan nationally, because it might be able to have a dramatic impact on decreasing the prevalence of HCV infection and also decreasing incidence as a result of the decreased prevalence. So I want to go back to where I started, and thank you for listening to my introduction, and to tell you that you're going to be hearing about 3 interesting presentations in Vietnam, Taiwan, and Uganda. Thank you.
Thank you, Dr. Lowy. And now I am delighted to introduce Dr. Jill Koshahal, who is a senior investigator in the Infections and Immunoepidemiology branch of the National Cancer Institute. And she will be speaking us today about circulating immunological markers in hepatocellular carcinoma.
Thank you so much for the introduction, Betsy, and really to all of the organizers for inviting me, and even more importantly, just for putting together this opportunity for all of us to talk and share about the work that we've been doing on hepatitis-related hepatocellular carcinoma. I'm really happy that I have the opportunity to share some of the work that we specifically have been doing on circulating immunological markers. And just to give you a little bit of background, hepatocellular carcinoma, or HCC, is strongly tied to inflammation. Hepatitis B virus and hepatitis C virus are 2 very major risk factors, very important risk factors for the development of this cancer. And both of them have impacts on inflammation and immune response. A few previous prospective studies have found associations between HCC and circulating soluble ICAM1, IGF-BP3, and IL-6. These previous studies have had limited or even no ability to try to understand how these markers relate to the development of cancer in chronically HBV infected or HCV infected individuals. So another limitation of these studies is that they tended to look at just a small number of proteins. So we felt that a more comprehensive evaluation of circulating immunologic proteins, specifically in the context of HBV and HCV, would be really useful. Unfortunately, we had the opportunity to do that in two existing cohorts in Taiwan, the REVEAL HBV and the REVEAL HCV study. Just to give you a sense of the overall design of REVEAL, from 1991 through 1992, individuals from 7 townships in Taiwan were invited to participate in a community-based cohort study on virus-related cancers. Over 23,000 were enrolled, and of those, 4,155 were positive for HBV surface antigen, which is an indication of chronic HBV infection. And then of those, 3,653 were HCV seronegative. Of the nearly 20,000 who were HBV surface antigen seronegative, 948 were anti-HCV seropositive. So this got us down to our cohorts that we evaluated in this study. And we proposed to extend the field beyond what had been done in previous studies by looking at a larger number of markers in REVEAL HBV and HCV, with the primary aims to evaluate the associations of hepatocellular carcinoma and immunologic markers in the context of chronic HBV infection and the context of chronic HCV infection, and then to compare how the patterns of inflammation markers were similar or different in HBV and HCV related hepatocellular carcinoma. And today I'm really going to focus on this third aim, associations that were identified both in the HBV and the HCV cohort. Oops. For this study, we used the Olink technology, which has a number of different panels, and we focused on the inflammation panel and the cardiometabolic panel. We chose the cardiometabolic panel because many of the proteins on this panel are actually produced by the liver. So we thought that could be particularly relevant for the development of hepatocellular carcinoma. Both of these panels include 92 markers. And we also, when we did the testing, we included blinded QC samples from 12 HBV infected and 11 HCV infected controls, which allowed us to evaluate how well these markers performed. And based on that analysis, we ended up dropping 82 of the markers, either because they were below the lower limit of detection in the majority of samples, or they had low intra-class correlation coefficients or high coefficients of variation. And that left us with a total of 102 markers for our analysis. For our primary analysis, we used polytomist logistic regression to compare hepatocellular carcinoma to non-cirrhotic controls and to cirrhotic controls. We ran separate models for HBV carriers and HCV carriers. Now, for right now in this talk, I'm going to focus mainly on the comparison between HCC and the non-cirrhotic controls, but I will come back to comparisons to cirrhosis just a little bit later on in the talk. Here you can see the adjustment factors for these models, and I want you to kind of keep these in mind because, again, a little bit later in the talk, I'm going to talk about some receiver operating curves based solely on these clinical and sociodemographic covariates compared to what happens when we add in immunologic markers. So just tuck that away in the back of your head. For the 3 a priori markers that I mentioned, we used a significance value of 0.05 to determine statistical significance. And for everything else, we used a false discovery rate of 0.1. So getting to the good stuff. Here you can see the odds ratios and the 95% confidence intervals for our 3 a priori markers, plus 4 novel markers that we saw were associated with HCC, both in the REVEAL HBV and the REVEAL HCV cohort. And here in this figure, REVEAL HBV is indicated by the black triangles and REVEAL HCV by the white circles. Just to remind you, an odds ratio of 1 indicates that there's no association between the immunologic marker and HCC. An odds ratio above 1 indicates an increased risk of HCC, and odds ratios below 1 indicate a decreased risk of HCC. And as you can see, of the a priori markers, only ICAM1 was associated with HCC in both the REVEAL HBV and the REVEAL HCV cohorts. Although the other two markers did sort of go in the same direction, the expected direction, with IGF-BP3 tending to have inverse associations and IL-6 tending to have positive associations. Of the novel markers, HGF and CXCL11 were positively associated with HCC, and SCF and CFHR5 were inversely associated with HCC. Then focusing on the markers that were associated with HCC, both in REVEAL HBV and in REVEAL HCV, here you can see the associations for people who had at least 10 years of follow-up. We wanted to get a sense of how long-term these associations were. And as you can see here, the associations with hepatocellular carcinoma typically remained even after we restricted the analysis to people with at least 10 years of follow-up, indicating that they do reflect long-term effects. And we think that that means that in the future, these markers potentially could be useful for risk prediction or early detections in populations with a high risk of HCC. But replication is really important, and we're going to come back to that in just a minute. These findings also have biologic plausibility, since the positively associated markers promote cell proliferation, survival, and angiogenesis, while the negatively associated markers have anti-inflammatory and anti-tumorigenic effects. And again, the fact that the associations remained even when we restricted to people who had at least 10 years of follow-up, so cancer didn't develop for at least 10 years, suggests that these really are long-term effects that can help us predict who's at risk of developing cancer. An important limitation of this study, though, was that we didn't have any information on underlying liver fibrosis. And advanced liver fibrosis can look a lot like cirrhosis, which might lead to the question, are these associations that we see with immunologic markers really only reflecting an association with underlying liver disease? To address that limitation, we wanted to assess whether circulating immunologic markers were associated with hepatocellular carcinoma among people who already had fibrosis and cirrhosis. And if we saw associations with cancer in people who already had fibrosis and cirrhosis, then it really does reflect an actual association with cancer. To address this question, we turn to the hepatitis C antiviral long-term treatment against cirrhosis, or HALT-C study. This is work that my postdoctoral fellow, Ilona Argirian, is leading. And many of these slides are hers, so I definitely want to thank her for the use of these slides. And this is a clinical trial that evaluated the efficacy of maintenance therapy with pegylated interferon alpha-2. And it found that actually this maintenance therapy didn't affect the risk of progression of fibrosis and developing HCC. They didn't see differences between the treatment arm and the control arm. And just to give you a couple of important points about the trial, it recruited people from 10 different sites in the US from the year 2000 through 2004, and included people who had previously failed therapy, who had advanced fibrosis according to liver biopsy, who had no history of hepatic decompensation and absence of other exclusion criteria, such as liver disease, other than hepatitis C itself. And one really valuable thing, among many valuable things in this study, is that fibrosis was assessed through liver biopsy, which has really been considered a gold standard. For this study, we included 94 individuals who developed hepatocellular carcinoma and matched 2-to-1 controls on those individuals. And again, we used the Olink inflammation and cardiometabolic panels. We actually ended up adding a third panel because it included IL-27, which Jianmin Yuan from the University of Pittsburgh presented at AACR a couple of years ago as having strong associations with hepatocellular carcinoma. So we wanted to be able to look at that as well. For this analysis, we used conditional logistic regression for individual immune markers and their association with hepatocellular carcinoma versus people who were chronically infected with HCV but did not develop hepatocellular carcinoma. And that was our primary analysis. But as something of a secondary analysis, we also took a look at the association between these markers and cirrhosis versus fibrosis among the controls who did not develop hepatocellular carcinoma. You can see the adjustment variables here. And again, we used 0.05 for a priori markers and a false discovery rate of less than 0.1 for everything else. Here you can see the odds ratios and the 95% confidence intervals for the a priori markers. And here I'm considering a priori those that had been found in previous studies, plus the reveal cohorts that I just presented to you, and then novel markers that were identified through this study. And what you see is that among the a priori markers, ICAM, HGF, and SCF were all associated with hepatocellular carcinoma, even among these individuals who had advanced fibrosis and cirrhosis. And that suggests that these associations with hepatocellular carcinoma and what we observed previously in REVEAL and in other studies were not due solely to underlying disease, but instead that they reflect a true risk of developing cancer. In addition to these a priori markers, we identified 7 novel markers associated with increased risk of HCC among people who already had advanced fibrosis and cirrhosis. Restricting to people who had at least 4.5 years of follow-up, again to try to get a sense of how long-term are these effects, we found that the magnitude of the association was generally as strong or even stronger among these people with at least 4.5 years of follow-up. And again, this suggests that these associations really do reflect long-term effects. Now, to touch briefly on our secondary analysis of cirrhosis versus fibrosis among controls, we found that levels of HGF and 5 of the novel markers were higher in controls who had cirrhosis compared to those who had fibrosis, suggesting that high levels of these markers are associated with more severe underlying liver disease, as well as with increasing the risk of hepatocellular carcinoma. Now, here I'm going to jump back to the REVEAL cohorts. I promised you that we'd come back to cirrhosis, and I wanted to dig in a little bit and look more carefully at hepatocellular carcinoma compared to cirrhosis. And here you can see among HBV-infected individuals, if you recall, our primary analysis was using polytomous logistic regression. And when we used that, we actually found that there weren't any individual immunologic markers that were statistically significantly associated with hepatocellular carcinoma compared to cirrhosis. But we also used another approach called canonical discriminant analysis, or CDA, where we could compare the baseline plasma levels among people who developed cirrhosis versus those who developed hepatocellular carcinoma versus those who developed cirrhosis. And this approach allows us to look at all of the markers together and identify which combination of these markers does the best job of distinguishing between cancer versus cirrhosis. When we took this approach, we found that there were 11 markers that differentiated individuals with hepatocellular carcinoma from individuals with cirrhosis. We then plotted the receiver operating curves, or ROC curves, for the model that included only those demographic and clinical variables that I showed you earlier. And then a separate curve for those covariates, plus these 11 markers identified through canonical discriminant analysis. The area under the curve was 0.87 for the clinical and demographic covariates only, compared to 0.89 for the covariates plus the 11 markers identified through canonical discriminant analysis. But these curves weren't statistically significantly different from each other. And you can see that in this figure. The curves are pretty much overlapping. So in this particular case, we didn't see that these inflammation markers or circulating immunologic markers helped us differentiate people who would develop cirrhosis and cancer versus those who would develop only cirrhosis. Things did look a little bit better for discriminating chronic HBV carriers who developed cirrhosis compared to those who did not develop cirrhosis. Here, polytomous logistic regression identified 6 markers that were associated with the development of cirrhosis, and canonical discriminant analysis found 9 markers that differentiated individuals who developed cirrhosis from those who did not. The ROC curve from the clinical demographic model produced an area under the curve of 0.63. And adding the 6 markers from the polytomous logistic regression models increased that AUC to 0.69. Whereas using the 9 marker model from the canonical discriminant analysis plus the covariates yielded an area under the curve of 0.79. And in fact, that area under the curve using the 9 biomarkers was statistically significantly higher compared to the clinical demographic model only. Now, moving back to REVEAL HCV. So we just looked at chronically HBV infected individuals. Now let's look at chronically HCV infected individuals. Here, when we compared cancer to cirrhosis, the polytomous logistic regression identified 4 markers associated with hepatocellular carcinoma versus cirrhosis. Canonical discriminant analysis found 14 markers that differentiated cancer from cirrhosis. And the ROC from the clinical demographic model produced an area under the curve of 0.73, which increased to 0.85 when we added the 4 markers from the polytomous models, and increased further to 0.95 when we instead used the 14 markers from the canonical discriminant analysis. And again, this model using the 14 markers was significantly higher than what you observed for clinical and demographic variables only. Comparing chronic HCV carriers who developed cirrhosis compared to those who did not, polytomous logistic regression identified 4 markers associated with cirrhosis, and canonical discriminant analysis identified 14 markers. The ROC curve for the clinical demographic model produced an area under the curve of 0.56. Adding the 4 markers from the polytomous model yielded an AUC of 0.75, and the 12 marker model, including the covariates, increased that AUC to 0.88. And again, that AUC for the 12 marker model was statistically significantly higher than that you get from the clinical demographic model only. And these findings suggest that these kinds of immunologic markers might help with the risk prediction, at least among individuals who have hepatitis C virus infection and cirrhosis. And the HALT-C study provides a replication for the REVEAL HCV study, but we still don't really have a replication for HBV. And that's kind of what we've been really thinking about now. How do we try to replicate those findings? One way that we've been thinking about trying to do that is by combining data from 3 different cohorts. The Shanghai Women's Health Study, which enrolled 75,000 women aged 40 to 70 from 1997 through 2000. The Shanghai Men's Health Study, which enrolled 61,000 men aged 40 to 74 from 2002 to 2006, and the Zhongshan City Cohort Study. And the challenge with Shanghai Women's and Shanghai Men's is that these cohorts don't currently have data on hepatitis B infection available. So to use these cohorts, we would need to test all of the hepatocellular carcinoma cases and quite a number of controls in order to find enough individuals with chronic HBV infection. And that's a lot of time and energy, and these are really precious samples. So we've been trying to think about what else can we do to make it worth this effort to do this kind of testing. And one thing that we've been considering is that in addition to allowing us to validate our REVEAL HBV results, we can also look at the prevalence of hepatitis D virus, which is a really important topic that hasn't received a lot of press and that we think is valuable to really dig into. And this is work that Tom O'Brien in my group has been leading. So by doing this testing, we could look at HDV prevalence in Shanghai and in China. And then we could also evaluate the associations between immunologic markers and HDV infection. But all of that said, honestly, I'd really love to hear from you all who are part of this webinar. Are there other ways that it would be valuable to you and to the scientific community to have HBV data from Shanghai Women's and Shanghai Men's? So I'm hoping we can have a little conversation about that at some point, or please feel free to follow up with me. Just to wrap things up, identifying factors that affect the risk of developing hepatocellular carcinoma could have important implications for patients with chronic hepatitis B or hepatitis C infection. And factors that affect the risk of hepatocellular carcinoma might offer important targets for prevention and treatment. And just as one example, HGF is already a target for hepatocellular carcinoma treatment, and it's being considered as a marker of liver fibrosis. So continued research into the novel associations that we observed might help identify additional opportunities for early detection and treatment. And with that, I will stop and take questions.
Thank you very much. That was wonderful. Does anyone from the floor have any particular questions? If not, in the chat, a question that came on early on was have you had a chance to evaluate the effects of Chinese medicine on any of these markers?
That's a really great question. And the answer is no. That's not something that we have dug into, but I am honestly increasingly becoming aware of traditional medicine and how it can have an impact on inflammatory markers. So that's a valuable future focus of research.
Okay, thank you. And another question that came in was did you see any differences between the time that samples were taken, if they were closer to one another versus a longer term or longer time separation between the samples? Did you see any differences?
So the analyses that I presented today were actually all samples that were taken from baseline or as close to baseline as we could get. We did actually do some testing of serial samples just to try to get a sense of how sort of stable these markers are, and it was not a large number of samples. So it's sort of hard to draw statistical inferences from what we saw. But what's kind of interesting is that many of the markers, when we had samples that were taken, say, a year from baseline, and then after that second sample, maybe 2 or 3 years later, there was certainly more variation in samples that were taken 2 or 3 years later versus those that were taken just 1 year apart. Things tended to look fairly similar over time for the cancer cases, but there was a little bit more variation among controls. And that, to me, kind of makes sense because the process that lead to the development of cancer is highly tied to inflammation. So you might expect to see higher levels in general, whereas among controls, somebody could have a cold or have something else that influences these markers and might cause a little bit more variability. Is that getting at the question?
Yes, I believe so. And then I had a follow-up question to that. Have you noticed anything or taken statistics in the history and physicals of your cohorts, any evidence of any other co-infections that are going on at the same time? I'm thinking particularly of HIV and perhaps an AIDS-associated malignancy like Kaposi sarcoma, because I know their levels of interleukin-6 are quite high.
Yeah, it's a good question. So in these particular cohorts, I believe for HALT-C that individuals with HIV were excluded.
Okay.
And for the Taiwanese cohorts, there's just not a very high prevalence of HIV. So it's not so much of an issue there. Something that we haven't looked at that I also don't know as much of an issue there would be like Salmonella typhi infection or something like that.
Well, certainly, yes. And then the last question that came in was, were the alpha-fetoprotein levels measured at the beginning of your analysis?
Yes.
Okay. And those are all the questions that came in, I believe. Anyway, well, thank you again. Great talk. And it's nice to know what's going on in other parts of the NCI, and always enjoy hearing what is going on. So thank you so much, Dr. Koshal. And now I will welcome Dr. Joanne Renata, my fellow program person in the Division of Cancer Prevention, NCI, and she will do the introductions for the next speaker. Thank you very much, and thank you again.
Thank you, Betsy. As she said, my name is Joanne Renato, and I'm a program director here in the Division of Cancer Prevention at the National Cancer Institute. And I have the honor of introducing the next two speakers. And our first speaker is Dr. Doan Dao, who is an assistant professor of medicine and the Division of Gastroenterology and Hepatology at Johns Hopkins University School of Medicine. And Dr. Dao's personal passion and professional commitment is the study and care of patients with hepatitis B virus. And he has worked in the HBV field, including clinical research, basic science training, patient care, and outreach and advocacy programs for more than 12 years. And Dr. Dao's research focuses on HBV cure. He also dedicates a large portion of his time and efforts in his native Vietnam towards viral hepatitis elimination. We have the privilege of having him speak to us today on preventing and detecting HCC in Vietnam, improving access to HBV and HCV screening, diagnosis, and treatment. So Dr. Dao.
Great, Dr. Renato. Let me share my slide real quick. Can you all see and hear well?
Yes, we can see your slides. I'm wondering if you can put it in maybe the presentation mode.
Let me see.
There we go.
Yeah.
That's fantastic. Thank you.
Yeah, if let me get to see, because I have the some of the just if you would to use to present. Let me see. Is it okay if I leave the slide this format?
Yeah, we can still see it, Dr. Dao. We can still see it.
Thank you. So thank you again, the NCI and the Coalition for Global Hepatitis Elimination of the Global Task Force for this opportunity. I title my presentation Joint Actions for Liver Cancer Control in Vietnam to signify the work that I will present is actually a result of a collective effort of multiple people, partners, sectors, both in the US and Vietnam. And I believe for us to continue to make meaningful contributions in the control of liver cancer in Vietnam, we would need to join hands and work collectively and collaboratively. So here's my outline of the presentation. I will provide some background of the liver cancer continuum in Vietnam. I will point out major gaps in the continuum. And to address these gaps, I will share with you all how and what we did as studies and as programs. And finally, I will finish by postulating our future direction towards liver cancer control in Vietnam. So on this slide, as highlighted in the world map, Vietnam is in red, located in Southeast Asia, and it is a low to middle income country with a population of about 100 million. It's a beautiful country where people are also pretty nice, I think. And due to my commitment and work in liver cancer area, I am able to live and work in Vietnam up to 6 months a year for it. And on the bottom graph, liver cancer rates in Vietnam are represented in the left panel, male. and the right panel is representing the female. And for male, liver cancer rate, as you can appreciate, has doubled over the past 2 decades. And for female, liver cancer rate in the country increased significantly over the same period. When we combine the male and female together, liver cancer is the most common solid cancer in the country. It is also the most common cancer-related death in the country since 2018. The adjusted incidence rate, just to give you some perspective, is about 23 per 100,000 in Vietnam for liver cancer. In comparison, the USA has an adjusted incidence rate of about 7 to 8 per 100,000. And as a result, Vietnam since 2018 has the 4th highest burden of liver cancer worldwide out of 195 countries with the liver cancer data reported. And another key point is that the trend in liver cancer in Vietnam is projected to continue to increase in the next 2 decades if there are no effective national interventional program. So on this slide, on the top panel, we use the cancer control continuum framework by the NCI to guide us on how to approach the liver cancer control in Vietnam. From the etiology standpoint, as you can see, liver cancer in Vietnam is primarily caused by infectious agent, specifically hepatitis B. And we all know that.
Sorry, Dr. Dow, I sorry to interrupt you, but is there any way maybe you can increase the size of your presentation?
Yes, let me see.
Because it's very difficult for others to see the information. So, okay.
Yeah, is it better?
Yeah, that is better. Thank you.
Okay. Thank you for pointing it out. In terms of liver cancer prevention in Vietnam, and as we all know, hepatitis B is a preventable disease by vaccinations and facilitation of screening and access to care of those who already been infected. Treatment for Hep C can decrease the risk, but there are residual risks of having liver cancer. So another aspects of liver cancer control in Vietnam is for early detection of those who already have Hep B and also increased risk for liver cancer. So in spite of these, preventable evidence-based practices for hepatitis B, the statistics in Hep B related liver cancers are still, I believe, startling. As you can see on the bottom left of this slide is an estimate of the liver cancer cases in Vietnam attributed by chronic Hep B infection. So hepatitis B infection is responsible for about 70% of the liver cancer cases in the country. And on the right panel, you can see that liver cancer at diagnosis, when patients have the symptoms, are already at an advanced stage where curative treatments are limited. And in fact, about 70 or 80% of liver cancers in Vietnam are diagnosed at stage 3 or higher. And I highlight the red there. So, so these are the major gaps in liver cancer control in Vietnam, hepatitis B, and the majority of them are diagnosed at a late stage of the disease. So after knowing these gaps, what have we done to help address these gaps? So before I share with you what the studies and the program that we've done, there are two more pieces of information that I like to present to give you a perspective on how we have been able to approach and work in Vietnam. So here is an overview of the public healthcare system and the medical education in Vietnam. And the system is organized under administrative hierarchy, with the central level under the Ministry of Health, and the local levels are under the provincial and municipal authorities that distributed throughout the country. And at each level, there's a two-arm system. One arm is focusing on prevention or preventative medicine, similar to the US CDC. And the other arm is focusing on the clinical care services delivery. And there are several key points here. The government maintains a strong concerted effort with both strong public health institution and healthcare capacity, in which the country leadership maintains the key independent determinant in shaping the health policy and implementing public health practices. The primary mechanism that they would be able to do so from the leadership standpoint is through this we call DOHA, or Direction of Healthcare Activities by the Ministry of Health, or the MOH. And the DOHA requires that public health institution at the higher government administration, these higher level, to support and empower the lower levels in the municipal or community healthcare centers in terms of providing public health programming or other community-based activities. And as a result, vertical communication within the healthcare system in Vietnam is purely seamless and considered effective for healthcare promotion, training for primary care setting, etc., as well as to educate the public health, especially the mass media. So, and the role of the medical education and public health educational institution is to train and contribute to the critical mass of the public health system in Vietnam. The reason I'm sharing that is that, for instance, in our case, when we work in Vietnam, we wanted to conduct our community-based screening and access to care for viral hepatitis, which I will show you in the subsequent slides. We will have to, for example, in Ho Chi Minh City, the highest authority in healthcare would be the health department of Ho Chi Minh City. And then from there, they would communicate to the commune level health stations so that we would be able to approach the community-based organization health station to implement our public health program. The other background information is that before we approach the liver cancer control problem in Vietnam, we also established two infrastructure and capacities as long-term strategies to help address the issue, the liver cancer public health there, because we wanted to signify to the local partners that we will come there, we will work with them, we will stay with them for a long term. And for this, the work that I will share with you has been done by the Vietnam Viral Hepatitis Alliance, which is registered in Vietnam, and it focuses on community-based program. And the Center of Excellence for Liver Disease in Vietnam by the Johns Hopkins University School of Medicine is to focus on capacity building, healthcare system, and academic programming. And to remind you again, for liver cancer control continuum, we given our expertise and resource we have, we would focus on more on the earlier parts of the continuum, and that would be to prevent viral hepatitis. And for those who already have it, we would focus on the early detection of liver cancer. So going back to hepatitis B, the question we posed at the time were, what were the gaps in hepatitis B continuum in the country? And as you may have been aware, for hepatitis B elimination, we wanted to focus on increasing access to diagnosis and treatment, because for Hep B elimination worldwide, the World Health Assembly endorsed the implementation of 5 core interventions, which have been demonstrated to be high impact, affordable, and cost effective. So in Vietnam, of the 5 core interventions, the 4 measures related to prevention, that would include childhood vaccination, prevention of mother-to-child transmission of Hep B, blood and injection safety, as well as the harm reductions, have relatively been established mostly by the national vaccination program and the HIV/AIDS program. And you may know that Vietnam is one of the beneficiaries of the PEPFAR. So HIV programs has been in Vietnam over the past 2 decades or so. So they are focusing on the other risk groups. For us, the only one core intervention that left neglected was the how to raise awareness, screen, and link people who are already infected with chronic Hep B infection. So that would be the 5th intervention core recommended by the WHO. The next question we asked was whether the country would have the national policy for hepatitis B screening and treatment and linkage to care. And indeed, Vietnam was one of the first countries in the world that released in 2015 the National Action Plan on Viral Hepatitis Elimination and Prevention. And then our other questions were, what were the Vietnam-specific barriers in the Hep B continuum and in Hep B elimination? And to us, there were several factors that quickly appear. Were one, we need the better data for Hep B. And in fact, in the first National Action Plan of Hep B elimination and prevention in Vietnam, they estimated that Hep B infection was somewhere around 8 to 25% in the country. So, and most of the data was from convenient-focused studies. To us, they were not representative data in the country. And then other questions we have include what would be the baseline continuum of care for Hep B in the country? Do we know the level of awareness in community as well as healthcare provider? And whether there was any other Hep B epidemiologic profile that we need to know before we can help address it. So in order for us to address these questions, we launched in 2019 a citywide study to determine hepatitis B prevalence and to characterize the Vietnam-specific barriers that I mentioned. We selected Ho Chi Minh City, the largest and the most diverse city in the country for the study. And Ho Chi Minh City, as shown here, is located in the south of Vietnam. And the middle panel is the map of Ho Chi Minh City. and it has a population of about 9 to 10 million individuals. So on the right panel is the public health sampling method that we deploy. And the method is the probability proportionate to sample size. By deploying it to, we representatively, I think the key term for us here is representatively invite and enroll 20,000 adults 18 years old or 18 years or older throughout Ho Chi Minh City for the study. And the panel on the right is the sampling approach. I won't go into the detail, suffice to say that we selected 100 commutes out of the 320 commutes in Ho Chi Minh City. And in each commute, we invited 200 individuals. And like I said, the study was conducted from 2019 to 2020. And around in the mid of 2020, we had to stop the study prematurely due to the COVID restrictions. So finally, we ended up enrolling 17,600 individual of the 20,000 individual blended. And that would represent 88 commutes out of 100 commutes we initially blended. And following the data quality check-in, we finally had a cohort of 14,765 individuals that with the complete data for final analysis. So that was the research methodology and paper. What does it look like in real life? What happened on grounds? So here I show you a commute health station where representative adults invited in the neighborhood come for the screening event. And as you can see, upon entry, they register and answer the KAP or knowledge, attitude, and practices questionnaires. And then they have their blood drawn. The blood collected, then courier back to central lab for testing and storage. And on the right panel, the middle picture is our outreach team comprising 4 to 5 healthcare workers, a doctor, and 1 to 2 phlebotomists. One key factor in our program was that we use 3 panel screening tests for hepatitis B. That would include HBsAg, anti-HBs, and anti-cold total. And for the Hep C, we use anti-Hep C antibody. And here are the results of the study. The prevalence of HBsAg positivity in Ho Chi Minh City on average is 7.5%, ranging from 5.5 to 17.5%, depends on the districts. And you can also see that there are there's a variation of HEPI infection rates among the 24 districts in Ho Chi Minh City, represented by the different degrees of the colors there. The gray areas are denoted unreachable size due to COVID restrictions. And on the right panel is the baseline linkage to care that we documented. So briefly, among the 1,157 persons with HBsAg positivity, and that number represents the 7.5% prevalence rate, the prevalence, we had about 70% were newly diagnosed. So that means they didn't know about hepatitis B before they enroll into the study. And about 30% were diagnosed before they participate in the study. So they were already they have already been aware of hepatitis B. And of the 345 individuals diagnosed prior to the study entry, the 30%, 165 of them, roughly 50% of them were engaged in care. And by engaging in care, that is those individuals who sought medical care from primary care provider or specialists in hepatology or infectious disease for hepatitis B management. The of the people who newly diagnosed for hepatitis B through the study, the number was 992 individuals. When after 3 months, when we call them for information on the follow-up, about 300 or 31% we were not able to contact and had the interview. So that left us with 629 individuals, or about 63%, who actually participated in the post-study phone interviews. And of those, about 24% or 148 out of the 629 sought clinical care and receiving clinical care management for Hep B after they know they had the Hep B diagnosis through from our study. The reasons, major reasons for those who miss or we missed calling them include that they gave us the phone numbers that did not work or the wrong numbers. And many of them also refused to answer the phone call when we call back. For the people who did not engage in care, major reasons include that they had a busy schedule, they had some other work to do, implying that they may not have been thoroughly educated about the importance of Hep B and Hep B liver cancer. Other two reasons include that they thought they felt fine without any symptoms, so they didn't need to seek medical attention. And another reason is due to financial concern. So on this slide, what I'm showing here is the prevalence of hepatitis B vaccine-induced immunity to hepatitis B among the adults 18 or older into populations in Ho Chi Minh City. One population is the general population, which is the population that we enroll in the study. And the other population is the non-infected population, defined as those who have never been exposed to Hep B, those who have negative anti-core total antibody. And on the y-axis is the birth year. I know it's a little it's a little to visualize clearly, but what I can summarize is that in the general populations, the one in yellow highlight, what we found was there was a higher prevalence of vaccine-induced immunity in the latter year, the people who were born in the latter years, while among the non-infected populations, the people who were younger had a lower prevalence of hepatitis B vaccination. And on the left panel, it illustrates the prevalence of Hep B naive or those who are susceptible to Hep B infections among the 24 districts in Ho Chi Minh City. And the prevalence range from 30 to 45%. So what about hepatitis C? As I alluded to you earlier, that we also test for hepatitis C. So on the far left panel, the prevalence of anti-Hep C antibody varies among the 24 districts, again, ranging from 0 to 4.7. And the average is 1.3%. And of those who are positive for anti-Hep C antibody, roughly 51% had a positive Hep C RNA. With that said, though, in the Hep C RNA negative group, we also know that about 50% of them reported having Hep C treatment prior to enrolling in the study. So the real rate for positive viremia among adults in Ho Chi Minh City would be around 70%. In the middle panel is the Hep C prevalence by the age and the gender versus the birth year. And here you can see that in the what we call the Vietnam birth cohort, those who were born between the year 1945 and 1964, this birth cohort comprises about 40% of all Hep C cases in Ho Chi Minh City. And on the far right panel is the baseline linkage to care or the care continuum of hepatitis C in Ho Chi Minh City. So in this study, we had about 300 study participants with positive anti-Hep C antibody. And you can see that about 28.5% of them reported knowing Hep C prior to the study entry. And of those who knew before they entered the study, most of them, like 78%, were coincidentally diagnosed with Hep C in routine health check or doctor visits, or when they admitted to hospital for different reasons. And of those who were aware of hepatitis C diagnosis, 82.7% of them initiated treatment. And of those who initiated on Hep C treatment, 53.6% of them had reportedly had a cure for Hep C. And we already disseminated this result scientifically. So next, what about viral hepatitis in healthcare workers in Ho Chi Minh City? So to answer this question, we, in a pilot fashion, conducted a mixed method study involving 203 healthcare workers for an HPV and Hep C serological evaluation, knowledge, attitude, and practice survey, as well as in-depth interviews. So we recruited this cohort as a representative sample of healthcare workers out of 4,000 healthcare workers in Ho Chi Minh City healthcare system. And as you can see here, the results are following. In this pilot study, 10.5% of them were infected with actively infected with hepatitis B, HBsAg positive. 0.5% of them had anti-Hep C antibody positivity, and about 28% of them had positive anti-Hep C core total antibody. 75% of healthcare workers in our study demonstrated adequate anti-HBs antibody, adequate immunity, defined as 10 IU per ml. And 50% of them, of the healthcare workers, reported that they not, only 50% of them reported that they always using gloves for clinical activity involving handling of blood or bodily fluid. So another 50% did not do it all the time. So, and then the other key finding in this study was that in the in-depth interviews of 28 healthcare workers, we reviewed two major concerns for most of the interviewees. The first concern is the need for financial support for Hep B and Hep C screening and treatment in healthcare workers in Ho Chi Minh City, and the need for HPV-specific guidelines to be independently developed. Because right now, the guidelines for viral hepatitis in healthcare professionals is not available. And most of the medical centers in Vietnam use the HIV guidelines instead. So up to this point, what I have shown you was the low education awareness of viral hepatitis in community, in healthcare providers. And another piece of data that I did not show was that in our surveys from the community, about 67% of all the participants reported that they would consider use some sort of rapid test, like a point of care rapid test for Hep B and Hep C diagnosis if offered. In order to, for us
Sorry,
to—
Dr. Dow, sorry to interrupt you. This is Joanne again. I just wanted to give you maybe a 2-minute warning that your presentation should be coming to a close shortly. We want to make sure that we stay on track and that we still have time for the last speaker as well, Dr. Kirk.
Great, thank you. So I will. So in order for us to respond to these deficiencies in education in various target group, we launched a comprehensive educational program focusing on the really basic information about viral hepatitis and liver cancer. And we also did that at the multiple levels, from community to primary care settings to a liver specialist and researcher. And in the subsequent slides, I wanted to show you some of these programs that we've done. This is for healthcare providers. And this is some of the community-based programs that we deploy to increase the community awareness and to help destigmatize hepatitis B in community through this Healthy Liver, Happy Life Health Fair. And these are some of the pictures we capture. And this is before these community-based event, we did produce short video clips to disseminate in various media outlets. This work was in collaboration with the WHO office in Vietnam. And here are some of the community-based program again. These are the programs that July 28 every year, we organize viral hepatitis scientific programs to commemorate the day. We invite the experts in Vietnam and abroad to participate. And then we also have a liver talk programs to focus on the trainees, the researcher in viral hepatitis. And this is the work, as I alluded to, that we wanted to promote point of care rapid tests in primary care setting. And here is a pilot program being implemented in 3 sites in Vietnam. And the next few slides is the what we have done to address the gaps in the late stage of Hep C diagnosis, HCC diagnosis in Vietnam, is to focus on the early detection methods and tests. And if you look at the evidence-based practices for early detection in Vietnam, you can see here ultrasound is already available in the district level. However, we still see about 70% of those who first time diagnosed with liver cancer presented at a late stage. So we thought the situation would be more complex and deep-seated. So we take one step back to propose to do a comprehensive analysis of the situation, and that work is being planted. In parallel with that work, we also launched a 5-year prospective international observational study for HCC early detection and high-risk individuals using liquid biopsies, and the study is called Stop HCC. And this work, we collaborate with the Saudi college because we know that they have a different risks of liver cancer. They have mostly metabolic risks for liver cancer. So I wanted to finish with this slide. What would be the future direction for us? I use the star here to signify that we hope that the future would be bright. And the star also has 5 points. In the first point, we wanted to focus still on the capacity building by strengthening and expanding our research capacity in research methodologies. We wanted to involve in academic, to work with academic and medical and public health institution, as well as the private industry, so that we can develop a co-financing model like public-private partnership. We wanted to leverage capabilities that built during COVID. For example, the telehealth system in Vietnam for suddenly developed really robustly during COVID. Maybe we can use that to communicate to do the training capacity building in the primary care setting. We wanted to also promote and integrate evidence-based interventions in primary care setting in terms of Hep B screening, access to care, and early detection method. And then the other really important factor is advocating the local government to take on this public health issue. And we wanted to develop a task force comprising of experts from community, various stakeholders, NGO, etc., so that we can promote for science for policy. And finally, what I have not shown you, but you may have realized that the data, for example, that I cite from Vietnam, mostly were from single or several center base. They don't have a unified, a surveillance unified system yet for viral hepatitis and liver cancer. So we wanted to, this is for a long term, that we wanted to work with them to strengthen the surveillance system for viral hepatitis and liver cancer to be more effective, efficient with an interoperable linking network. And for this work, we anticipate it will take decades. And the lesson we learned was that in the HIV arena, for example, with the relatively a lot more resource in HIV than viral hepatitis in Vietnam. Like I said, HIV program has been a beneficiary of the PEPFAR program, and it took them almost 20 years to have a well-established surveillance system. And for us, for viral hepatitis, we anticipate it will take a long time to get the system to be more effective. So
thank you very much, Dr. Dow. We need to move on and to be for courtesy to the other speakers. Thank you so much for a very in-depth presentation. I'll turn it back over to Betsy.
Okay.
Thank you.
Thank you.
Hi, this is actually Joanne Renato here. I would like to introduce Dr. Kirk as our final speaker here. And Dr. Kirk is a professor of medicine at Johns Hopkins University of Medicine, and he holds appointments in oncology as well as the Bloomberg School of Public Health and Epidemiology. And his areas of clinical expertise include epidemiology, hepatitis, HIV, AIDS, and infectious diseases. And for his presentation today, he will be talking to us about understanding the link between HIV and acceleration of liver cancer, findings from research in Uganda. Dr. Kirk?
Great, thank you. Are you able to hear me okay?
Yes, we can hear you, but we can't see
Great.
anything right now. Just, there we go.
And are you able to see a single screen, or are we doing the dual screens?
We can see a single screen, but it's small.
It's in presenter mode. I'm not sure. It's the standard presenter mode. I don't think I can do anything about that. So thank you to the organizers. Is it readable?
It's readable, yes, yes. Hopefully you don't have
sorry
small
about that.
font.
It's presenter mode, so I'm not sure. But
Okay.
thanks.
Go ahead.
Good afternoon, good evening to those in Africa, maybe good morning to a few others. Thanks for the opportunity, and thanks for NCI for making sure that liver cancer is recognizable as one of the most important causes of cancer death, but I think I want to share with you some of my thoughts and some of my experiences, and hopefully end for such a dismal diagnosis. I think there's reasons for some optimism in the coming year. So with that, I'll present some data from our ongoing studies, predominantly in Uganda, about how liver cancer presents, the survival, causes of liver cancer, how we can identify and screen those at high risk, with an emphasis on the impact of HIV infection at each of these different factors. And then I'll end up with some other more musings about strategies for interrupting cancer, particularly those of infectious origins, and what we can do to control liver cancer, and perhaps also, as Doan mentioned, leveraging HIV care infrastructure for prevention and control. I'm going to talk to you mainly about our ongoing studies, really built out of a long-term partnership between Johns Hopkins and a variety of different institutions in Uganda. We started the HIV and HCC in Uganda study. It's been 10 years ago. I've been working with colleagues, particularly Dr. Pansiano Ochama in Uganda, since around 2006. And we started the HIV and HCC in Uganda, or HTU Consortia, with funding from NCI as part of the U54 program project grants. I'm going to present a little bit of data about our HCC case control study and our screening study among HIV-infected persons. First of all, we instituted a case control study recruited from 3 different hospital sites in a couple of different regions, predominantly in the central Kampala region, as well as in the northern region, where we've noticed a much higher chronic HBV prevalence than in other regions of Uganda. We recruited controls from 2 different populations and did a very standardized and extensive and very thorough evaluation, asking lots of questions, a focused clinical exam, a standardized ultrasound exam, as well as a variety of laboratory studies. We originally were going to recruit 600 liver cancer cases and an equal number of controls. We actually ended up, for a couple of reasons, to double that number of controls to have 2 different control groups. We diagnosed liver cancer based on a suspected HCC undergoing an ultrasound with space-occupying lesions and elevated AFP as our diagnostic criteria for the great majority. On a smaller subset, they would actually undergo a liver biopsy that was particularly based on where they were identified, where they were used to doing liver biopsies, and also if the AFP was non-diagnostic. We basically had controls recruited from those specific clinics or the trauma ward who were free of overt liver disease. This is the unfortunate face of liver cancer in Uganda, as well as in much of sub-Saharan Africa. Instead of the 60-year-old that Doug Lowy was mentioning here in the United States, we're talking in the around 40 years of age, a substantive male predominance. More than half of our liver cancers were chronic HBV infected. A smaller proportion had antibodies to HCV. And we had 18%, almost 1 in 5, that were infected with HIV. Of those with HIV, most of them had been previously diagnosed. Most of those had been on ART and had been doing well with viral suppression. So they had been in contact with the HIV care system prior to this diagnosis of hepatitis, of hepatocellular carcinoma. We did a standardized assessment of a number of symptoms that might be present at diagnosis. And here I'm presenting both in the lighter shade, those who are HIV negative, and in the darker shade of coloration, the HIV positive cases. And whether you're looking at the symptoms or signs, first you notice that there's a triad of hepatomegaly, so abdominal pain, enlarged liver, and frequently weight loss really occurred in about 90% of liver cancer cases. And in fact, if you did the performance characteristics of that as a clinical case definition, it actually performs quite well in the absence of any ultrasound alpha fetoprotein or other sort of additional measures, unfortunately. But we don't see any differences in the clinical presentation by HIV status. The symptomatology, the physical findings were very similar, despite the presence of HIV. What we do see is very multifocal disease. So this does not prevent at early stages. The great majority have multifocal disease, often not just a couple of lesions, but multiple lesions, many times with the background cirrhosis also present. These are important because the likelihood for curative localized therapies, as well as potential resection, those are more limited in this population with advanced presentation. And unfortunately, this is a West African photograph from many years ago when I was working there, that a pregnant man delivers in his grave. And we did document among this large number of liver cancer cases with survival follow-up that the median survival was only 6 weeks, not 6 months, 6 weeks was the median survival, if you look right here. With such a rapid progression to mortality, it's actually difficult to distinguish factors that might accelerate this process. So HIV status really didn't have a dramatic difference. We did see some signal that those with more advanced immunosuppression with HIV, those in particular, those with CD4 less than 200, had a more rapid progression to mortality. But again, this is in the backdrop of largely uniformal and rapidly fatal disease. This is our main etiologic findings, in which, as would be expected, hepatitis B, and in this case, we had an over 20 odds ratio for being surface antigen positive in liver cancer risk, about a 4-fold increased risk with hepatitis C, both of those as would be expected. We did find, particularly in the ENT and dental clinics, significantly about 2.5-fold increased risk for liver cancer with HIV infection. And perhaps even more intriguing was the fact that a very high proportion of our liver cancer cases expressed urinary antigens for active infection with schistosomiasis and had a 4-fold higher risk. This was interesting to us. We also noted an interaction between schistosomiasis and liver cancer risk, with schisto exposure alone associated with about a 2- or 3-fold increased risk. Again, that 24-fold higher risk associated with chronic hepatitis B. And if you look at the joint exposure, it's approximating a multiplicative effect of the two individual exposures. We were concerned that this schisto association might simply represent confounding by where people were or being exposed to water or other things like that. But as you can see, the 4-fold increased risk was very consistent irrespective of region. We looked at other sort of water sources as well, with the lone group of being surface antigen positive being a more attenuated risk associated with schisto. And this, from an epidemiological perspective, when the risks are reduced, that suggests there could be a common pathway involved in both schisto and HBV, leading to increased risk. When we look at that data, interestingly, we see that, again, these two columns simply compare a variety of HBV markers in those with schisto in the first column versus those without schisto in the second column. So in terms of just exposure measured by anti-core positivity, we have a higher proportion of exposure among those with schisto. There is more schisto in some of the regions of the country where hepatitis B also is known to have a higher burden. But then among those with core positivity, we find a notably higher rate of chronicity, with 50 compared to 30% by schisto status. And among those, we note the higher level of detectability as well as a 10-fold higher level of HBV DNA among those with active schistosomiasis infection compared to those without. So this prompted us, well, in terms of take-home points from the case control study, we're able to recruit a pretty large number of cases within a few years, documented the rapid mortality. We note this interesting interactive effect of hepatitis B and schisto. There's a main effect of HIV that we also see with our, in particular with our more appropriate control group of the outpatients. And I didn't have time to go into aflatoxin. And in interest of time, I'm going to skip over that as well. We also wanted to look at our, sorry about that, we wanted to look at our HIV positive patient population. So at the Infectious Disease Institute in Kampala, we screened about 1,950 patients at baseline, again with a rigorous evaluation that include a non-invasively measuring fibrosis with FibroScan, rolled if they had significant fibrosis cirrhosis by FibroScan or had viral hepatitis markers that were rolled into long-term follow-up. And we have identified a handful of liver cancer cases through this study. As would be expected, we documented the male predominance as well as risk associated with chronic Hep B and HCV as being factors which contribute to fibrosis. In addition, in a summary of more detailed data, those who had not been on active ART were markedly higher risk. We saw this increasing dose response effect of longer durations of time on antiretroviral therapy being associated with a protective effect. Notably, for most of the history of ART regimens widely available in Uganda, there's been some level of HBV active medications incorporated as part of them. And for the great majority, they are now on a Truvada containing regimen with a couple of active HBV antivirals. We also found increased risk with HBV DNA, particularly at around 10,000, but our mutational analysis was not so compelling in terms of additional risk beyond viral load or other markers. So take-home points from this investigation was that we can recruit and follow HIV positives at risk for liver disease. Consistent with other data, there's a significant loss of surface antigen and protective effect of antiretroviral therapy among the co-infected individuals. There was some signal with our CD4 load with fibrosis. We also noted, and this has been replicated in other studies around Uganda, that 40 to 50% of individuals are neither vaccinated to be protected, nor have they been exposed as a child. So a substantial proportion are susceptible to hepatitis B. Additionally, in another setting, we've documented that it's actually been hepatitis B and among the adults in Uganda are actually at risk in relation to, so both HIV and the number of sexual partners is a risk factor for chronic hepatitis B. So the nature of the modality of transmission for hepatitis B in Uganda is changing from what was purported to be predominantly childhood transmission, and you likely were exposed and protected for life, even among those who have not yet been, among the cohort older than vaccination, there's a substantial number that remain susceptible. And we also were able to operationalize liver cancer screening with 6-month visits. But again, the incidence is relatively low, even among a higher risk cohort. So our take-home point, again, myself as an HIV viral hepatitis epidemiologist, is that we have infectious diseases that can be treated with a possibility of prevention or cancer interception strategies. So we have a variety of different modalities, and additionally for evaluation of these approaches, we have in most cases measurable and reversible endpoints that can be looked at without waiting until clinical diagnosis of liver cancer might be made. With this and with the call for funding for additional renewals or expansions of these program project grants, we formed with our partners in Senegal, particularly led by Moussa Seydi and Gilles Wandeler, who have been doing very comparable work to what we were doing in Uganda. We evolved from the H2U to the H2A consortium with representation then from both East and West Africa. And our goals with this next 5 years of funding have really been to develop a broader cohort looking at the natural history of chronic hepatitis B, screening for liver cancer with the biorepository, looking at potential biomarkers, as well as much more detailed mechanistic investigation into this interaction between hepatitis B and schistone. There's the broad aims. Again, my apologies for going a bit fast, but I'm trying to make up some time. So I just want to mention some of the barriers to liver cancer control in Africa. And this is really sort of from my viewpoint and in discussions with my colleagues, largely from Uganda. Vaccination uptake in Uganda, probably a 70 to 80% compliance or adherence to childhood vaccination, but that doesn't include the birth dose for those that might be at much higher risk. Birth dose in most of sub-Saharan Africa is largely not readily available. Part of that is because antenatal and adult screening for HPV is also largely not available. Even among most HIV clinics in sub-Saharan Africa, hepatitis B surface antigen is not routinely tested. There's been a difficulty in trying to get tenofovir or those non-ART, Truvada as part of ART is much more widely available than is tenofovir. We need better screening strategies. As is mentioned, it's a very dismal diagnosis. We need to advance and find a way to identify people at earlier diagnosis, whether it's through biomarkers, as Jill was discussing, or other approaches, including liquid biopsy that Doan mentioned. We really need better markers of higher risk. If we are able to identify earlier diagnosis, we need to make sure that we have curative treatments available. We tried to provide support for interventional radiology to do localized curative therapy in Uganda. It's been a real struggle. In a population of 45 million in the country, there's never more than 2 to 5 individuals who might be able to perform these interventional radiology approaches for potential cure of those who might be diagnosed earlier. We're pleased to say there's been about 5 liver resections for early HCC, perhaps some that were more palliative in nature, but we've never had a liver cancer surgeon until recent years able to perform any type of liver surgery. We recognize that there's going to be a substantial number of persons who are going to be diagnosed at advanced stages, and we have little to offer them. And even if better pain control and a more holistic palliative care approach could be improved, that would really be important for management of liver cancer in this setting. Finally, all of these barriers happened in the presence of an overburdened healthcare system that struggles to take care of routine issues, much less consider prevention and control of cancer. So my colleagues, and hopefully we have some time for Professor Ochama to weigh in after my talk, they've really taken the lead in working towards leveraging the HIV care model, as well as the existing infrastructure for liver cancer control in Uganda. Ponciano has launched a project recently where he's going to screen up to 37,000 pregnant women at different referral hospitals in the country to try to deliver both the birth dose as well as antivirals to mom and baby as appropriate. We recognize that adult vaccination with 50% or more of the population at risk, we need to integrate approaches for, I'm not sure why this is advancing. We need to integrate approaches for adult vaccination. In a study led by Uni Manana among high-risk female sex workers, we note that there was a pretty reasonable completion of the 3-dose, but a very high completion of 2 doses has raised us to consider some of the new alternative vaccination schedules, as well as some of the novel hepatitis B vaccines that might be appropriate, particularly for high-risk populations. Doctors Ochama and Joan Mutoba from the School of Public Health at Makerere University have done a lot of work in integrating HBV diagnosis and treatment into routine HIV care, training the providers, demonstrated cost efficiencies, but there's a significant loss to follow-up. And that's led to them also now recently launching peer support for improving engagement in HBV care. all of these things, whether it's PMTCT, that model has been very well advanced in the setting of HIV infection. Treatment and engagement in care, making sure that people continue to come back and engage in care and take their medications. That's certainly been, all of these are HIV care model issues that we've struggled over the last couple of years. I did my doctoral dissertation 20 years ago, just before the rollout of ARTs was available. And there was a clear skepticism that that could be achieved. I think in many cases, there's been skepticism that we can aggressively and widespread treat hepatitis B, identify and diagnose those that need treatment, and hopefully care for those who are eventually diagnosed, preferably at earlier stages. But I go back to the skepticism that existed before PEPFAR, before 20 million persons are on antiretroviral care across sub-Saharan Africa and growing each year. So I think we need to take lessons from HIV care delivery model, leverage the infrastructure, and hopefully that will be of benefit as we try to eliminate hepatitis and liver cancer in Africa. In conclusion, I think we know a lot about the etiology. We have a lot of recognition about hepatitis B and C. I think the next phase in terms of etiology is really about exploring these co-infections and cofactors, as mentioned, both schisto as well as aflatoxin and hepatitis delta. We're working as well on liquid biopsy and other biomarkers, which might identify individuals at greater risk for liver cancer so we could target screening efforts more appropriately. We still have a lot of work to go in terms of making sure that efficacious curative treatments are identified as well as made widely available. But we have a lot of things in our toolbox, vaccine and antivirals in particular. We have a great model and infrastructure to expand in the terms of the HIV care model. And I think what we really need to be leveraging and working towards is to develop the resources, the mobilization of community and individuals around particularly sub-Saharan African countries to also support these efforts for diagnosis, management, and treatment of hepatitis and liver cancer in these settings. And with that, I want to acknowledge the long-term partnership with Ponciano, a professor at Makerere University in Uganda. I want to also recognize the growing work with our Senegalese colleagues, Moussa Seydi and Gilles Wandeler, who've been working there for a long time. Without going into details, it's a partnership of many different investigators from Uganda, Senegal, as well as at Hopkins. I want to thank Geraldina for her advocacy for amongst NCI and broader amongst the NCI malignancies group to make sure that liver cancer is not a forgotten malignancy amongst those HIV-associated cancers. And then finally, to thank our large and productive staff and the willingness of the participants to work with us. And with that relatively rapid approach, I think we might have made up a little bit of time, and happy to take some questions now, or if you want to give Dr. Ochama a chance, whatever is your preference.
Thank you very much, Dr. Kirk. I just want to maybe one question, and then I will pass it back to Dr. Ward. One question here is that, have you looked into using FIB4 or APRI scores to assess fibrosis, given the limited access to FibroScan?
Yes, we have looked at some of those, and they perform pretty well. And I think actually in terms of both looking at people who have fibrosis in the absence of the availability of biopsy defined or even non-invasive FibroScan, those certainly are approaches. They have their limitations, and some of them can be, but some of those could be integrated, and they are being integrated into approaches for defining treatment need for HBV antiviral therapy. They're not great, they're not perfect, but they're helpful.
Thank you. And there are some other Q&As
Sure.
that you may want to take a look at later. But with that, I want to pass it back to Dr. Ward.
Thank you, Joanne. I'm about to pass it over to my colleague Ponciano, who as Dr. Kirk mentioned, is an associate professor at McCary University and is involved in a number of studies as where it was touched upon. And he's also president of the Uganda Gastroenterology Society. I really appreciate him coming on and give some additional perspectives from his studies and practice in Uganda. Ponciano?
Thank you very much, organizers. Thank you, Greg, and all the presenters. Greg has actually talked about most of the things that we are doing in Uganda, but I will take it on from there. First of all, the hepatitis B is the major cause of liver cancer here in Uganda, both in HIV and non-HIV infected patients. And as was mentioned, it presents very late, and most of our patients are dying very quickly, and they are living only for about 1.5 months from the time of diagnosis. And so they are really presenting with stage B disease. Of course, government has had a number of programs to try to reduce the incidence of hepatitis B in this country. For example, we are testing for hepatitis B, HIV, HCV, and syphilis in the blood transfusion service, and consequently leading to reduced transmission through those processes. Also, in the year 2002, government introduced the pentavalent vaccination for the babies given at 6, 10, and 14 weeks post-delivery. And it has been relatively successful, actually, largely. And also introduction of auto-destructive needles so that you don't have to continue using these needles. And earlier on in the year 2004, we had a national series survey that showed Uganda had about 10% of the population nationally with chronic hepatitis B, most of it being the northern part of Uganda. And as you go south, the burden goes lower. In the north, we had about 20 to 25% of the population having hepatitis B. In the south, and especially in the southwestern part of the country, this was about 4%. And in the year 2015, government launched massive testing of hepatitis B in the whole country, actually. And that was about 6 years ago when we started. And we planned to screen 17 million adolescents and adults in the country. At that time, by the end of the 5 years, we were able to screen at least 5 million, and we identified about 370,000 with hepatitis B infection. But there were some challenges with this. First of all, the intention of the vaccination was to vaccinate all those who were surface antigen negative, and link all the surface antigen positive persons to care. Yes, most of those who actually tested negative got the first dose of the vaccine, but by the time they were getting the third dose, they were only about 18% of those who actually got the first dose, got the third dose, because of the difficulties in trying to get these persons back to care, to get the vaccination. And eventually, the program was not very successful in terms of the vaccination, but those who were identified as positive were actually linked to care. Government opened up hepatitis B clinics in all the regional hospitals to take care of these persons. But these clinics were really not well served at all compared to what we were seeing in the HIV clinics, which have got a lot of funding. I mean, quite a bit of funding from donors and the rest. And that was the reason why we went on to try to test the integration of the hepatitis B in mono-infected patients into the HIV setting, which we did in 2 sites in the most prevalent areas. And this was in form of, we did this in form of implementation science research, and it was quite successful. 2 years ago, this program ended what we were doing, but to date, all the patients going to those hospitals are actually being taken care of in the HIV clinic. And we were very happy. We're now trying to see how we can roll this out to the other parts of the and the other hospitals in the country. Now, in 2016, there was another sero survey. Remember, the pentavalent vaccine was introduced in 2002. The first sero survey was in 2004. In 2016, we had another sero survey, which now shows the national prevalence of hepatitis B dropping to 4%. And this is really quite appreciative. But the report from the Ministry of Health is still showing about 3,000 children getting infected every year with hepatitis B. Now, that talks a lot about the vaccination program and how it is going using the pentavalent vaccine and the lack of the birth dose. And that has led us to set up this other program, which Greg talked about, to do the PMTCT, HBV PMTCT study. Actually, I spent the whole of today doing protocol training for that study. And we plan to screen 37,000 pregnant women and then identify those who are positive and divide them into 2, those who have high viral load. And here we are using 20,000 as the cutoff. Those who are more than 20,000, we are giving them tenofovir, and those who are less than 20,000, we observe them, but at birth, all the babies get a birth dose, and then we follow them and see at 9 months post-delivery to see what is going to happen in terms of the infection in the babies that have undergone this. Of course, the babies will have to go on with the pentavalent vaccine as well to complete, so they will receive like 4 doses. We are hoping that this will have some impact. Recently, the NITAG, the National Immunization Technical Advisory Group, approved birth dose, but government doesn't have the money to really procure this birth dose. Fortunately for this study, they used the hepatitis program money to procure for us the birth dose. But we are going to certainly have some challenges to really introduce the birth dose nationally. And we hope that this, the finding in this study will help actually to convince them to continue with this. I think that's what I can say. And we are hoping that the burden of liver cancer will begin to drop down with time, because we still have a huge population with chronic hepatitis B, especially those adults who, in most cases, got this infection in early childhood. Thank you very much.
Thank you very much. You really augmented what Dr. Kirk was illustrating for us in Uganda. And Dr. Kirk, I don't know if you have any other brief remarks following Ponciano.
No, I think Uganda's a case study that I think is very perhaps generalizable to many other African settings. There's struggles at all different levels, but I think there's growing interest and opportunity.
I agree. Thank you. And just to comment myself on what Ponciano mentioned about some of the challenges of implementing this recommendation by their NITAG for hepatitis B birth dose and some of the challenges in implementation. There was a decision several years ago by the Gavi executive board for Gavi to support implementation of hepatitis B birth dose, but then that was put on hold because of the response to COVID-19. Now that we're moving from pandemic response to pandemic recovery, we really want to let Gavi know that it's time to lift the pause button on that support. Please join me in looking for ways to communicate that to Gavi. One of the ways we're doing it is conducting a survey of immunization programs in Africa to get a better sense of their priorities for hepatitis B birth dose and the importance of Gavi support for implementation. Thank you. I'll turn it back over to Betsy and Joanne for a wrap up.
Well, hello. Thank you, speakers. That was fabulous. I think you gave us a wonderful illustration of the global health efforts in looking at hepatitis elimination by different factors and different populations. I'm really quite pleased with this and enthused. And, hopefully going forward, we're going to, be able to implement or add on to some of the strategies of what you're currently doing. Do you have any additional comments, Joanne?
Thank you, Betsy, and thank you, John. I want to again reiterate and thank all the speakers for their wonderful presentations, and also for giving us an overview of the global health issues associated with liver cancer, and then also the role of HIV, because when we look at patients, it's the entire patient, or schistosomiasis in addition to viral infection. So having these various interplays of these other infections in addition to Hep B or Hep C, I think is important factors to bring out and to address the challenges associated with that. So, but again, I want to thank all the speakers for their excellent presentations today.
And I would also like to add, I would like to mention my colleagues who helped suggest the speakers within NCI. I think they did a fantastic job. Dr. Geraldina Dominguez, Dr. Jonah Kaliba, Dr. Ann Chow from the Center for Global Health, as well as Dr. Satish Gopal. So thank you all for suggesting you all as speakers. I think this has been fantastic.
I agree.
Thank you for joining us.
Yeah, thank you. Thank you. Thank you, Betsy and Joanne. Thank you, NCI colleagues. Thank the speakers. Thank everyone on the webinar today for your attention to this. I learned some new aspects of HCC care that I was previously unaware of. So it was definitely informative for me. Please, go to our site at globalhealth.org to get the materials that I mentioned at the start of the program. And also please sign up for our Twitter at Global Health or to our newsletter, and we can give you update as when the next webinar will be held. So thank you again. And thank you to my colleague, Lindsay Hebert, for directing all of this production. Thank you.
Thank you.
Thank you. Thanks.
Thanks all. Good afternoon.
Thank you.
Thank
all.
you. Bye-bye.
Thank
Bye-bye.
you.
Bye-bye.
Thank
Bye, everyone. Thank you, Lindsay.
Thank you, everyone, so much. Great job.